Phantom Limb Syndrome by Maddie, Terrace, Kenzie, Katie, and Nikki. Today, we're going to cover what phantom limb syndrome is, why it's important, what pathways and structures are involved, and its clinical applications. PLS is a common syndrome among amputees, which is characterized by the ability to feel sensations and pain in a limb that no longer exists. PLS can be characterized by painful sensations, such as burning, shooting pains, or pins and needles, and non-painful sensations, such as perceived movement, or external senses, such as touch, temperature, pressure, vibration, and itch. PLS was first discovered by a French surgeon who operated on wounded soldiers and wrote about patients complaining of pain in amputated limbs. PLS is important for understanding neuroplasticity and the body's ability to remap the primary somatosensory cortex. 80% of amputees suffer from phantom limb syndrome. It's a real-life issue that can cause a great deal of chronic pain and decreased quality of life, and we're interested in explaining the condition and its treatment options.
Phantom limb syndrome is still somewhat of an enigma. There are many current theories about how phantom limb syndrome develops. In a review article written by Subedi et al., they mentioned 4 explanations that most likely affect the somatosensory pathways in combination. These theories include the development of painful neuromas in the periphery, hyperexcitability and disinhibition of nociceptive neurons in the spinal cord, reorganization of the somatosensory cortex, and the somatic effects of anxiety or depression. For the purposes of our presentation, we will focus on the most often cited theory of phantom limb syndrome, which is the reorganization of the somatosensory cortex.
All sensory pathways are involved in the phenomenon of PLS, but for this presentation, we will focus on the dorsal column medial lemniscus pathway. The dorsal column consists of the axons of sensory neurons. In healthy individuals, somatosensory information travels up the dorsal columns in the gracile or cuneate fascicle. Somatosensory information decussates from the ipsi to the contralateral side in the inferior medulla and continues its path through the medial lemniscus. From here, neurons synapse onto nuclei in the thalamus, which relay the information to S1 via the internal capsule. The sensory homunculus indicates how somatosensory information is organized in S1. There is a larger representation for areas requiring more dexterous control, as well as areas with a larger number of receptors, such as the hands, lips, and feet. In the case of phantom limb syndrome, there is a reorganization of the cortical circuits in S1. For example, an amputated hand will cause the hand afferents in S1 to wither, and in response, adjacent areas will take over. The arm and face areas are next to the hand area in the primary somatosensory cortex, so an individual with PLS may feel referred sensations of pain in their amputated hand when the arm or face are stimulated.
Phantom limb syndrome is a highly debilitative syndrome both mentally and physically. The treatment methods try to incorporate cognitive, sensory, motor, and emotional therapy with the primary objective of reducing and managing pain. Some of these treatment methods include, but are not limited to, progressive muscle relaxation, mental imagery, the use of TENS, and mirror therapy. For the purpose of this presentation, we will focus on the effects of mirror therapy. Mirror therapy has been found to be an effective treatment method for phantom limb pain, or PLP. In the study by Foad et al., it was discovered that mirror therapy reduces PLP by lessening dysfunctional cortical representation in S1 and decreasing inferior parietal cortex activity. Overall, there is no one treatment method that is more beneficial over the others, as they all depend on the individual. The factor that plays the largest role in treatment success is the patient's willingness to buy into the treatment itself.
Created using Powtoon.